Hello and welcome to the Osteoarthritis Action Alliance Lunch and Learn webinar for May 15th, 2024. Thank you for joining us. We are pleased to present our first of two Lunch and Learns this month in honor of Arthritis Awareness Month. Our presenter today is Ewa Roos, who is a professor in the Faculty of Health Sciences and Department of Sports Science and Clinical Biomechanics in the Research Unit of Musculoskeletal Function and Physiotherapy at the University of Southern Denmark. She has a passion to advance the frontiers of knowledge in muscle and joint health. Her focus is on patient-reported outcomes, exercise therapy, surgical treatments, and clinical care pathways. Professor Roos is the author of over 300 peer-reviewed publications. Her work is cited over 26,000 times, and her H-index is 74. For 30 years, she has published methodological papers on patient-reported outcomes in groundbreaking randomized trials, comparing exercise therapy to orthopedic surgery in high-impact journals, such as the New England Journal of Medicine and the British Medical Journal. Professor Roos is an internationally leading researcher and change agent in the field of musculoskeletal health. She has been able to produce high-impact methodological and clinical research and translate that research into patient-reported outcome measures, including the KOOS, HOOS, and FAOS, and clinical tools such as Good Life with Osteoarthritis in Denmark, or otherwise known as GLAD. The title of today's presentation is Good Life with Osteoarthritis in Denmark, 10 years, 10 countries, and over 100,000 patients. Welcome, Professor Roos.
Thank you for the kind introduction. I'm happy to be here for the next 30 minutes and talk about GLAD. And I would like to talk a little bit, how did we get to 10 countries and 100,000 participants in 10 years? And what is GLAD, really? So just a little historical background here, and I'm using knee OA as an example. It could work just as well with hip OA. But total knee replacement was introduced in 1968. And total knee replacement is a really good treatment, but it's not for everyone with osteoarthritis. And there are different studies from different countries, but it looks like actually only a fraction of those that we see in primary care fulfill the indications for surgery. And there is a substantial proportion that reports chronic post-operative pain. And systematic reviews haven't found any preoperative interventions that could change the post-operative outcome. So there is a need for other treatments for knee and hip osteoarthritis. The first exercise trial was published in 1992. And 10 years later, the benefit of exercise was clear. And how did we know that? Well, this is a cumulative forest plot where here are all the studies that were published from 1992 to 2012 during 20 years. And they are ordered in the year of publication. And on the right here, you have a little estimate with whiskers. And this is an effect estimate, and the whiskers represent the uncertainty. And then there's a cumulative plot. So here is the result of the first and the second study, the first, second, and the third, etc. And if we follow this plot down to around 2002 here, we can be sure that performing yet another study will not change the fact that exercise is osteoarthritis medicine, and the effect is a moderate effect. So we've known for a long time that exercise is good for people with knee osteoarthritis. And this is actually part of a much larger trend where we can see that exercise therapy is actually much better than we thought it could be, not only for osteoarthritis, but also people with a meniscal tear or people with an ACL injury. And unfortunately, surgery is not as good as we hoped it would be. So how has exercise been mentioned in treatment guidelines? And I'll I've just listed some examples here where I have been involved personally in the development of these guidelines. So what has happened from 2003 to 2020 is that there is increasing evidence, and therefore exercise was just mentioned as a possibility in 2003, and in 2011 and 12, it was recommended as a treatment. And in the latest clinical guidelines that I was involved in, it had a high priority. So that is what has changed with the cumulative evidence over time, but it has been mentioned for 20 years. And this is about where we were when we started GLAD. So it was recommended in national treatment guidelines, but it was not really there in the clinic. So we engaged in discussions with public healthcare regions in Denmark, where I work, to launch the idea that we should actually follow the clinical guidelines in treatment of osteoarthritis in Denmark. And after 3 years of discussions, the result was basically, well, this is a really good idea to follow the national treatment guidelines, but it's going to be so difficult to implement. So nothing happened. And it has very little to do with research evidence, but it had a lot to do with what I think we can categorize into the categories politics, organization of the healthcare sector, where often surgery is organized in secondary care and exercise in primary care, and also financial incentives. So after 3 years of discussion, I was very frustrated, and I had been involved in clinical guidelines for a long time, and I knew the evidence was there. So I teamed up with Soren Skov, who was my PhD student at the time, but who is now my fellow professor. And we just decided, let's do something about it ourselves, because we were so frustrated. So we actually started a strategy where we decided not to speak to the healthcare sector, but to talk to journalists, because we wanted to increase awareness of exercise as treatment for knee osteoarthritis, that it actually was an option. So here you can see we were very busy. And we had also done large randomized controlled trials that we could push out in newspapers. And here you can see the Danish Minister of Health, and we got her to do the exercises, to try it out. We increased awareness for politicians as well. And we got some famous physicians in Denmark to write about this, and things changed slowly. But what changed everything was when it was on the news, where the most famous general practitioner in Denmark said, you should exercise your pain away. And here it says direct, which means breaking news. And we thought that was so embarrassing, because we've known this for so long, but the patients hadn't. So this changed everything, because these patients then started to go to their GPs and ask for exercises treatment. And at this point, we had developed the GLAD. And what is the GLAD? Well, the whole aim with GLAD is to bridge the gap from research evidence and treatment guidelines to the treatment that is delivered in clinical care. That's the whole idea of GLAD. And in most instances, implementation happens top down. But we were only physiotherapists, and we had never read the great book about implementation. So we did the only thing we could. We did it bottom up, and it grew in an organic way. And we had a lot of input from clinicians and patients on how to do this. And we also collaborated with Sweden, who had a similar program in place. So if you think about the options that most general practitioners and surgeons have to prescribe evidence-based care for osteoarthritis, there are not very many, because what they can do, they can take a prescription pad and they can write a prescription for a paracetamol or an NSAID, and we all know that they are not very effective and there are many side effects of these drugs. They can also write a referral for imaging, and we know that imaging is actually not required for the common diagnosis of osteoarthritis, and because it's a clinical diagnosis. And GPs can also write a referral to an orthopedic surgeon. So the surgeon can then decide if the patient is eligible for surgery. And I've been working a lot with orthopedic surgeons over the years. And many of them are actually quite frustrated because they think that they get the wrong patients. They don't get those that need surgery. And at least in our countries, they would say that of those that they get into, that they get a referral for, at a maximum 50% fulfill the requirement to have surgery. So we wanted to develop the missing piece, which was that you could refer to evidence-based patient education and exercise therapy. So what is GLAD all about? I'll show you a little video.
Ja, det er jo et rigtig, rigtig fint tilbud for patienterne. Det har vi efterlyst mange år i praksis. Det er sådan, at det er en meget stor patientgruppe, og vi er nu glade for, at fysioterapeuter nu kan tilbyde dem en behandling, som har effekt inden for det her område. Det har vi manglet.
Der er ikke nogen tvivl om, at GLAD har højnet niveauet i praksis, og det har gjort, at vi er sikre på, at vi lever op til de kliniske retningslinjer. Sådan som jeg føler, så er det ligesom om jeg har fået mig et helt nyt liv. Og jeg føler mig overbevist om, at jeg ikke skal have et nyt knæ. Og det var jeg ellers bange for.
So GLAD really consists of 3 components. It's a 2-day course for clinicians where we talk about osteoarthritis in theory, about management of osteoarthritis, but we also have a lot of practice sessions. So all clinicians get to practically test all the exercises, both do them and they change and take part if they're a patient or a clinician. And we also use some clinical tests for monitoring, but they also learn during these days. So the clinicians that become certified to deliver GLAD, they then go back to their own practices, and that could be in public care or in private care, and they deliver patient education and exercise for 6 to 8 weeks. And there is also a registry where clinicians and patients register data, and they also learn about that during the course. Sorry, there was something that came up here on my computer. Okay. Sorry, I just lost something here. There we are. Sorry for that. So in the patient education, that is 2 or sometimes 3 times 60 minutes, which is led by a physiotherapist for the 2 first sessions. And if there is a 3rd session, that is led by an expert patient. Patients and the physio talk about what is osteoarthritis, treatment, all kinds of treatments for osteoarthritis, and self-management for osteoarthritis. And we also try to bust some myths and provide fact about osteoarthritis. You all know that moving is osteoarthritis medicine, but I just would like to clarify what I'm talking about here, because when we're talking about GLAD, that is what I would categorize as exercise therapy, which is a program of adapted physical activities that are prescribed for therapeutic purposes. And the whole aim of these exercises is to reestablish normal function in muscles and joints and to lower pain caused by injury or disease. But that is not to say that exercise is not good. For, of course, exercise or moving and physical activity is really good for people with osteoarthritis, but GLAD is exercise therapy. And we think that's a really good way of starting and getting going. And of course, the goal is that once you have improved your function and your trust in your osteoarthritic joints, that you should be able to participate in the exercise and physical activity of your choice. So the type of exercise program that we use is a neuromuscular exercise program. And what is that? So I would like to talk a little bit about what that is and about some aspects to consider when you would like to roll out an exercise therapy program large scale, like across the whole nation. So neuromuscular exercise is exercise therapy that focuses on the osteoarthritic joint. And in this case, that means that we use two kinds of input that relates to the joint to progress or regress the exercises. So it would be the physiotherapist's visual impression of the quality of the exercises. And it would be the patient's pain report following exercise. This is different from strength training, where the aim is to be able to lift higher loads and build muscle mass, or aerobic conditioning, where the aim is to improve the cardiovascular output. And again, this is not to say that aerobic conditioning and strength training is not relevant or good for people with osteoarthritis, but that's just not what we are doing in GLAD or have focus on. There are, of course, elements both of strength training and aerobic conditioning. Neuromuscular exercise requires supervision and feedback. And we think that is an important part because if you have a coach, in this case, a physio, that can help you with anxiety and fear, which is common in these patients because it is often painful when they start exercising and they need someone to hold their hand to overcome that. So for those of you who really would like to know more about neuromuscular exercise, I would like to recommend this review that we wrote some years ago. So neuromuscular exercise is really the same, it builds on the same principles as the type of exercise that we use for young people with an ACL injury or knee injury who are at high risk of developing osteoarthritis. And we use this type of exercise for them to return to sport. It's also the same type of exercise or the same principles that you use for exercise programs to avoid knee injury. So we use the same principles, but we have adapted the exercise for middle-aged and older people with a lower functional level. So our program, our neuromuscular exercise program has a warm-up component. We have a focus on core exercises, on joint control or segment control, muscle strength, function, and then there is one part about gait and cool down and stretching for the knee patients. And we usually show 4 different levels of exercise. And those are suggestions and recommendations that we have found work well when you can progress. But you should use the principles for progression, which relates to the length of the lever arm, the kind of surface, the body position, etc., to progress and regress these exercises. So if you're a skilled clinician, there are many, an infinite number of adaptations of these exercises that you should use for your patients. But this is a good way of starting and getting into neuromuscular exercise. We also use pain, and a pain monitoring scale. we have found this really effective because it can help patients better understand how much is appropriate load, because patients worry about doing too much. And I worry about them doing too little because I would like them to improve. So this is a system that was developed a long time ago for adolescents with anterior knee pain, but it works very well in this context as well. So we ask patients to rate their pain after exercise and in the morning on a 0 to 10 scale, using safe, acceptable, and avoid categories. And we teach them 2 simple rules, and that is that the day after training, the pain should subside to pain as usual, but they are absolutely allowed to have pain when they exercise. And the morning pain should not increase from day to day. So this is from a study where we recorded the pain before and after each exercise session in a study. And what we found was that there is an acute flare, which is a response to exercise that on average for this group of OA patients was 0.7 or so on a numerical rating scale. And as you can see, the difference, that the pain flare diminishes with time. And it's very helpful to tell patients, yes, you can expect pain when you start to exercise. That's not dangerous. It is because you're doing something that you're not used to doing and your body's not used to it. But it will diminish with time. And that's very helpful information. So we actually have patients record both their pain after exercise and their progression. And this is a way of making it very visually clear to them that maybe the pain is not subsiding in the start. Maybe they have the same pain, but they can usually see that despite that, they're able to progress the exercises. They can do more. And that's also a kind of improvement. And I think this is part of self-management and empowering the patients to continue with exercise on their own, because they know how to adjust what they do. So let's talk a little bit about what is important when you're rolling out an exercise program nationwide. And I would say the absolutely most important aspect is safety. And the reason why we choose this particular program is because we know it is safe. We have done many feasibility studies, even in those with severe osteoarthritis, waitlisted for osteoarthritis. And we have applied it in many, many scientific studies. And now we have also applied it in more than 100,000 patients. And it works, and it is safe, and there are no serious adverse events. And as you can see, there are pain flares, but they usually diminish with time. NIMIX has comparable pain relief to other programs, so it's not better for pain relief, but it has a lot of benefits. It is safe, it is feasible for patients to do, and we can teach it to clinicians. It improves the trust in the osteoarthritic joints, and it is meaningful. That is very, very important. We think it is important too that it requires the need for supervision and feedback for the reasons I just mentioned to you. It uses very inexpensive equipment, so patients, that should not be a barrier. And it's fun to do when it's group-based. And all this translates into good adherence. And what is unique for GLAD is that of the patients we have in the register, more than 80% have participated in at least 10 supervised sessions. So the most common patient that participates in GLAD is a 65-year-old overweight woman with knee pain. And knee patients have typically had longer symptoms for a longer time, and they're more overweight than hip patients. And comorbidities are very common in GLAD. So 2 of 3, of OA patients, 2 of 3 have at least one more other medical condition like high blood pressure, cardiovascular disease, or diabetes. And as I said, 2/3 are overweight or obese. So what are the results? Now you have to remember that this is not a randomized controlled trial. This is a quality registry in clinical practice. So this is what we can see in clinical practice, and there is no control group. So we can see that there is a pain relief. We can see that many people stop taking pain medication or switch to a pain reliever with a better safety profile, for example, from NSAIDs to paracetamol. We can see there is an improvement in walking speed and an improvement in quality of life. And these are the improvements we see directly after the treatment. And what is important and very promising is that we actually can see that the results are sustained at 1 year. And that translates into that GLAD is cost effective on a 2-year horizon. And again, you have to remember that this is a cohort study and not a randomized controlled trial, at 1 year. And what was interesting here was that we could also see that the number of sessions were important. So those who had good adherence, they had lower healthcare costs. Patient education and exercise therapy, I think they should always be combined. I would never deliver exercise therapy again without patient education. That's a really important combination. It is interesting because it looks like it can at least delay and maybe even prevent surgery. So the first randomized controlled trial that we did that got a lot of attention was 9 years ago, and that was published in New England Journal of Medicine. And we randomized people either to have total knee replacement directly, followed by a 3 months post-operative package of non-operative treatment, or to have the non-operative treatment package alone. And we could see in the group that only had that they were all eligible for having their joints replaced, but who only had the non-surgical treatment package for 3 months. 3 out of 4 had not had their joint replaced within 1 year. And at 2 years, still 2 out of 3 had not had their joints replaced. In this group, they had about 30% pain relief, and that was obviously enough for the great majority not to turn to the surgeon and ask for surgery, because of course they could call the surgeon whenever they wanted to. And in Australia, they've done the math, and they have demonstrated that if you have 12 patients getting the GLAD program, it's only one of these 12 that needs to avoid surgery for the program or for GLAD to generate savings. And for your information, in our program in Denmark, at 2 years, it was 30% who had had their hips replaced and 10% who had had their knees replaced. So it's a relatively small proportion. And we could also see that those who improved from the program, they had a lower likelihood of getting surgery. So there are some myths that we have busted, I think, with this program. One is that clinicians want to do their thing. And I think we've found that it is possible to empower clinicians to, with confidence, deliver care according to clinical guidelines for osteoarthritis. And we have trained almost 10,000 patients as of December 31st last year. We also, one thing that we heard when we started talking to the healthcare sector about this was that people don't want to do this. They don't want to spend time. They want quick fixes. They want the surgery. But I think we have proven them wrong, because as of now, it's a lot more than 100,000 patients only in our registry. And of course, there are many other patients who've had this kind of treatment. So many patients actually want to treat their osteoarthritis this way. Another important thing was what one of our GPs told us. He said, I don't want to refer to physiotherapy because I'm not convinced it works. And I have to say he's right. because physiotherapy is not a treatment. To me, it's a profession. And physiotherapists, they can deliver a whole range of treatments. Some of them are evidence-based and some are not. So he's right. And we've found that they actually prefer to refer to a program with a known content. They know what it is, and they know what effect to expect instead of physiotherapy. So GLAD is a success. And in 2019, it won the Value-Based Healthcare Prize, and this was fantastic, not only for us, but I think also for physiotherapists all over the world, and for MSK disorders all over the world, because this was the first time that it was a program or something that was not led by doctors that won. And it was the first time that it was not cancer or brain or some other kind of sexy disease, that it was actually an MSK disorder and osteoarthritis. So I think we all should share this prize. It was great. So GLAD has, as I said, spread over the world, and there are 10 countries now, and we collaborate in something called GLAD International Network, do research together, and we are also a support group and help each other with barriers and facilitators for implementing GLAD in different healthcare systems. And in 2018, GLAD Back was developed, and that has spread to some countries. And you can see there is a little dot for US here too, and that is because we've done a pilot project in the US. So with that, I would like to thank you for listening, and if there are any questions, I'm happy to respond to those.
Thank you so much for that presentation, Professor Roos. It's just really interesting to hear the details and sort of the origin story of GLAD, and so how you developed it over time. And the Osteoarthritis Action Alliance is very pleased to have added this program to our current list of recognized arthritis-appropriate evidence-based interventions in our last review process. With that all said, we'll open it up to our Q&A portion. So if you have any questions, like Professor Roos said, please go ahead and add them into the chat. We have one that came up earlier. Somebody was wondering, are the psychometric properties of the HOOS-12 and KOOS-12 robust enough to be used in place of the originals?
Yeah, well, thank you for that question, which is completely unrelated to this presentation, but I'm happy to respond to it anyhow. So the KOOS and HOOS 12 are short forms that only hold 12 items instead of 42. And it was developed and tested in people who have their joints replaced, because in registries you usually would like to have shorter forms. So yes, it is tested for those groups, and the psychometric proportions are robust enough. If you're going to use it in younger populations with a higher physical activity level, I suggest that you add the remaining questions from the sport and rec function subscale as well to cover their physical demands.
Awesome. Thank you for that. Just one question for me. Wondering, if we are clinicians in the US, what would a person need to consider if they're interested in implementing GLAD here?
Mm-hmm. Well, it is a big undertaking to implement a program like this. And what we have learned over the years is that it takes a great deal of effort and hopefully funding to do it, and a team. So it can take maybe a year before you're ready to launch such a program. And what is different with this program from many other programs is actually that we are collecting data. And that is not that common, at least not here in physiotherapy care. But that has been absolute of utmost importance, because that is the way we have been able to show to policymakers that this actually works and that patients are happy with it. So data collection is a requirement and a mandatory part of GLAD, and that makes it different from all other usual physio courses that you take. So I think you should be aware of that. And what we have learned is that it usually requires that there is a university partner But in some countries, universities have teamed up with another organization that could be a professional organization or something else who will deliver the courses. So there are different setups in different countries. And there are actually also countries like the Netherlands and China where GLAD was introduced by orthopedic surgeons because they wanted to have an alternative to surgery. So there are very different models or ways of making this happen in different countries.
Wonderful. Well, thank you so much, Professor Roos. Thank you to everyone who attended today's talk. In just a moment, we're going to launch a brief satisfaction poll about today's presentation. So if you're able, please answer those questions before you leave the webinar. And finally, we will host a second Lunch and Learn later this month in honor of Arthritis Awareness Month, highlighting the other newly recognized arthritis-appropriate evidence-based program. We hope that you can join us in May for the 29th for a pre-recorded presentation with Rachel Nelligan, who will discuss the My Knee Exercise program. Links to the registration for that event and future Lunch and Learns will be included with an email for today's presentation recording. Thank you so much, everyone, and have a great day. Thanks again, Professor Roos.
Thank you.